Thank you, Dr. Mohit, for giving me this opportunity to be with all of you. Uh, it was, we had some wonderful talks, and we are missing Dr. Dilpreet Singh. Unfortunately, he's not with us. His father is ill, and so he's taking care of him. So we wish all the best, and we hope that his father recovers soon. So moving forward, I'll be talking on the wrong choice of intraocular lenses, and I'll be dealing with a couple of my cases here. So this was a case of a 35 years old male and who had a history of retinitis pigmentosa with the NS grade 2 plus with posterior subcapsular cataract. So we did an uneventful phaco in this patient and implanted a hydrophilic lens which went in the bag. So this patient comes after 4 years, and what we see here is an anterior dislocation of the bag in the anterior chamber, as you can see here. So what went wrong here? So as we all know, like since I was dealing with the case of retinitis pigmentosa, now these have weak zonules. They have progressive zonulopathy, as in cases of pseudo exfoliation syndromes. And so with time, in these cases, the capsular phimosis occurs because of the unopposed capsular bag fibrosis. And later on, you may end up getting a late IOL subluxation or a dislocation, which can be anteriorly or posteriorly. So as you can see here, the whole bag, it came in the anterior chamber. So we enlarged the wound here, and I had to remove the lens along with the bag. You can see here the lens is entangled in the bag. So I'm now removing the bag from this entangled lens. And you can see here the shrunken bag. So this was followed by an anterior vitrectomy, and then an anterior chambered intraocular lens was implanted. You can implant a scleral fixated lens or a glued IL in these cases. So what went wrong here? Wrong choice of IOL. We used a hydrophilic acrylic intraocular lens. Well, single piece acrylic lens are easy to implant and they avoid additional stress on the zonules, but they don't resist the capsular contraction syndrome. So in this case, actually a 3-piece IOL would have been better. It is larger, it is rigid lens, and it prevents capsular phimosis. So we should have implanted this lens. This is another case of a 36-year-old male with a posterior subcapsular cataract with a high K readings. And I implanted a toric IOL in this case, and I got a surprise. Now, when we did topography in this case, we noticed that we were dealing with a case of a keratoconus. Therefore, IOL calculation and selection is very, very important in these cases. We know that we are dealing with high amounts of irregular astigmatism in these cases. And therefore, for moderate or low-grade keratoconus cases, you may go for a toric intraocular lens, but if it's a little advanced and when they have irregular astigmatism, toric IOLs don't work. So what happens is here is that the visual axis is not at the apex, but at the slope of the cone. And therefore, the readings that we get, the keratometric readings that we get is only of the central or the paracentral area. And so we can miss out on the actual K reading. And therefore, IOL power calculation is difficult in these cases. Also, what we can do here is, like, if you have an optical biometry and you do an IOL master, always look for the standard deviation of the keratometry. When you do an IOL master here, you see these values, the SD values, the standard deviation values. Now, if it is more than 0.20 diopters, which is expressed as a 0.03 millimeters, if it's more than 0.03 millimeters, then it means that we are dealing with an irregular astigmatic patient, and therefore we need to do a corneal topography in these cases. Another case was a 76-year-old male who had a mature cataract and a senile myotic pupil. This patient wanted a trifocal implantation. So we went ahead, did an uneventful phacoemulsification, implanted the lens in the bag, and what we get is a poor near vision. The patient was very unhappy post-operatively, and then we noticed that he had a myotic pupil, as you can see here. Now, what happens here is when we are dealing with the trifocal lens, the central zone has the refractive zone, while you have the peripheral diffractive zone, which is mainly used for near or intermediate vision. Now, when you have a myopic pupil, the iris covers all the diffractive zone, and you are left with only the central refractive zone, which is for the distance vision, and the near and intermediate vision is compromised. So therefore, the patient is unhappy as he is not able to see for near vision. This is another case of a 52 years old male who had undergone LASIK 18 years back, had a grade 3 nuclear sclerosis cataract. We did optical biometry, and which turned out to be an IOL power of 15 diopters. We went on straight ahead and implanted the lens, and we got a post-operative refractive surprise. Patient had the post-operative hyperopia. His unaided vision was 660, which improved to 6.6, but with the refraction of +3 diopters. So what actually happened here? Now, what happens is that when we do a LASIK or a PRK, what it affects the anterior corneal surface. So the anterior corneal surface changes, but the posterior corneal surface remains unaltered. So there is an anterior and posterior, power ratio shift, and the cornea's effective refractive index has been altered. So therefore, we will not able to get a true K value here. So in these cases, what happens is that when we do the myopic correction, the corneal power is overestimated, and the IOL power gets underestimated. So we get a post-operative hyperopia, and that's what happened in this case. So it's very important to collect all the pre-operative data of the patient, analyze the corneal map. If you have devices, go for a ray tracing where you can see the corneal asphericity, post-corneal astigmatism, the corneal aberration, and always under-promise these patients. Always under-promise and over-deliver these patients. You can also use the IOL calculator here, the ASCRS post-refractive surgery IOL calculator, where you have to fill in all the data here. If you have a pre-LASIK refraction, the keratometry, then the post-operative refraction, keratometry, the K values, the ACD, the axial lens thickness, white to white, all these, whatever data you have, you just put this inside it, and then you will get an estimated IOL power, which will help you in getting these post-operative surprises. This was another case where we did a phacoemulsification and then PCR occurred, and we implanted a single piece acrylic IOL. Now, sometimes you don't have those 3-piece lenses in your inventory, and then things can become very difficult. So we implanted this acrylic lens, and when we saw this patient post-operatively, we saw that there is a sunset sign here. Now, in these cases also, hello, now, am I audible? Now,
yes.
Okay, so now in these cases, what happens is, since these IOLs can get decentered, and if you look at this picture, the haptip rubs the posterior pigment surface of the iris, and which can lead to uveitis, glaucoma, hyphema, the UGH syndrome. So the good choice would have been a 3-piece IOL in these cases, as the optics overall, the size of the lens is big. It centers well in the sulcus, and the haptics, they are angulated in such a fashion that the optics don't rub the iris, and you can even go for an optic capture here, where the lens can be well stabilized. So a 3-piece would have definitely be a better choice. Another case scenario where he had a 48-year-old male who was myope, had a nuclear sclerosis of grade 2, and prior to cataract surgery, his refractive error was -2 diopter, and we did a biometry and then implanted a monofocal intraocular lens in this case. And the patient was absolutely miserable after surgery. He had complete loss of accommodation, and despite of him having a vision of 6.6 and good vision for near with the +2.5 diopter, he was not happy. And when we explained the patient that he just has to use glasses for near, he said that it's really weird, because I have never used glasses for near all my life. It's for the distance that I've been using glasses, and for near glasses I have not used glasses, and now you have done the reverse. So it is important to treat every patient individually, discuss with the patient, provide the best possible vision to the patient. For these myopes, you should overcorrect the IOL power to slightly make them myopic so they are good in, so that they can read without their spectacles. You can even go for the presbyopic correcting IOLs in these cases. So it's important to give time to the patient and get to know what he really wants. And I would like to highlight here another case that this was when we are doing multifocal intraocular lenses, it's very important that we should implant the lens right in the center, and it should be in between the visual axis and the center of the pupil. Now, if you understand this diagrammatically, you see here, now we have this visual axis, which is a line drawn from the fixation light to the fovea. And then we have the pupil, the center of the pupil. And if we draw a line perpendicular to this center, we get the pupillary axis. So the angle between the visual axis and the pupillary axis is the angle kappa, which is actually very important. So what happens is, now, if you look at this diagram, you will find that in the center, you have the visual axis here, and then the center of the pupil here. So the intraocular lens, the center of the trifocal should be in the center here. And you can also get this kappa value when you do an optical biometry. Now, if you look here, when you do the white to white, when you see the white to white values, down below is a value, is the kappa values. You see the px and the py. When you add px and py, it should be less than 0.6 millimeter. If it is less than 0.6 millimeter, that means that this patient is good for a trifocal lens. And then the patient will not have halos or glare. But if it's more than that, then this patient is, you should avoid putting a trifocal lens in this patient, as he may complain later on. So to conclude, it's important to do a proper surgical evaluation in all our cases. We really need to plan our surgery carefully. We should be very diligent and skillful with our surgical techniques, and always give time to the patient. Choose the proper IOL which is to be implanted. Maintain your inventory, so that, because once you have started off the surgery, there is no going back. So you should have all the lenses that you require, and you should put the proper IOL. Thank you.